2, 1. Hi, thank you so much for tuning in to our third live Facebook video for National Suicide Prevention Month. Today we'll be discussing mental health and suicide, and we're joined by a few of Centerstone's experts on this topic. And I'd like to go ahead and just make a disclaimer that we're all working from home, so you might hear some kids or cats or dogs in the background or anything, so please just bear with us if that's the case. And I'll give it a few more seconds for people to join, and then we can get started. All right, so I think we can get started now. I'll go ahead and introduce myself. I'm Michael Sostre, and I'm the PR coordinator for Centerstone. And I'm joined by some folks who are going to be here to talk about mental health and suicide, like I said before. So I'll go ahead and turn it over to Bree Banks to introduce herself, and then we'll let our other speakers also introduce themselves.
Hi, all. My name is Dr. Bree Banks. I'm the Director of Clinical Education at Centerstone's Research Institute.
Awesome. Now I'll let Jashari introduce herself.
Hi, my name is Jashari White. I am a clinical therapist here in Chattanooga, Tennessee, where I'm the clinic manager as well as coordinator for our community-based services.
Awesome. And now we'll let Bob introduce himself as well.
Yeah, and I'm Dr. Bob Boxley. I'm the Director of Clinical Education for our internship and psychiatry residency program in Florida.
Awesome. So I'll go ahead and start just by announcing that you'll be able to see in the comments that we'll have some information throughout the video. So we'll have some crisis line information there. So yeah, just keep up to date with all that stuff. And I'll go ahead and start by asking Bree a question. So we've been talking a lot about suicide and prevention efforts this month. And a recent report by the CDC shows some startling statistics in the number of people having thoughts of suicide. Can you walk us through some of those results and why this might be happening?
Absolutely. And to avoid just going through all of the boring stat stuff, one of the things that we've seen in the suicide risk and the rates of suicidality specifically is what we're seeing is spikes in populations or in groups of people that we don't commonly see as being particularly high risk for suicide. And so when we think about who are the folks, the demographics that we typically see at very high risk for suicide, the highest risk groups are middle-aged white men, anywhere from 45 to about 65. That's the highest risk group. Those are the folks that are most likely to die by suicide. And what we found is that group, the relative risk hasn't really increased, or rates of suicidality or attempts or deaths haven't changed that much. However, what we've seen is rates of suicidality and suicide attempts and deaths among young and young adult African Americans, frontline workers, participants of that work in, or people that work in hospitals, folks that are, again, these kind of frontline workers, these folks that might not otherwise have these kind of high or particularly high stress jobs, are really, really showing up for us as being at particularly high risk for suicide. And so we think, and as well as kids younger and younger and younger. So we're seeing spikes in suicidality or reports of suicidality for children as young as 6. And those rates just going up quite a bit over really over the past few months. And as well as people who are homeschooling and working from home. And so when we think about why that might be happening, I think we can look to a particular theory that explains suicidality, and it's called the interpersonal psychological theory of suicide. And it was coined by a guy named Dr. Thomas Joyner, who's at Florida State University. And in this theory, he identifies really 3 core predictors of suicidality and high-risk suicidality. One is called thwarted belongingness. And what that is, it's a notion of a sense of lost connectedness. And so when we think about these family members and these parents or these folks that are working from home that don't really have that social connection to the same degree they did before, that could be contributing to their suicide risk, just that sense of isolation. Another is a notion called thwarted belongingness. And so thwarted belongingness is essentially the notion that my death would be worth more than my life, right? So I am a burden on those around me. I would be doing the world a favor if I were no longer around. And so what we've seen in the COVID-19 pandemic is unemployment going through the roof, right? And folks not being able to participate in school the way they were historically. So what we've seen is this notion of I can't contribute to my household, I can't find a job, I can't support myself or those around me. And so that really does promote this sense of burdensomeness, this notion that I just might as well not be here. And so when we take a look at those two things, and then we finally have this notion of acquired capability. And acquired capability is essentially the notion that it's hard to die by suicide, and then a person has to practice or essentially get some exposure to the idea of dying through a fearlessness about death as well as practice. And so one of the things that we've also seen is most of the time when people die by suicide, they're likely to die by a means they have in their home. And so when people are just at home all the time or much more often, the accessibility to their means is quite a bit higher. And so those are just a few of the things that could be predicting to this really unique spike in suicidality and suicide attempts that we've seen since COVID-19 kicked off.
Gotcha. Thank you for running through all of that. My next question is for Jashari. So you manage a team of Centerstone mental health providers in Tennessee.
Yes.
And so what do you tell people who may be experiencing suicidal ideations?
So when our clients come in for sessions and they are experiencing suicidal ideations, we want to do a series of screenings to really assess for their level of intent or their means, their access. Do they have anyone in their home that can help restrict those means to the access that they have? So we'll use the Columbia screening to determine where they are with their suicidal ideations, really going over thorough assessments to make sure or to see what access they have to complete a suicide, or, if it's really an intent or if it's just a lingering thought. If we feel that a client really does have suicidal ideations that could, unfortunately lead to their death, we would definitely call our mobile crisis line to do an assessment, to assess, to make sure, to see if they just needed to create a new safety plan or if they needed to be hospitalized. And at that time, we would encourage the client to follow back up with us, after their stay in the hospital, to make sure that we're continuing with therapy, provide medication management if necessary, and making sure that the client has the best quality of life while in treatment with us.
Great. So there's actually a question in the comments about attempts with home items. So what can we do to make sure that our home is safe, especially if we're gun owners, service members, or have standard things in our medicine cabinets?
Absolutely. So with the gun owners, you want to make sure that those guns are locked, that they are out of access for anyone who may be suicidal and or homicidal. You want to make sure that they're in a safe place so that they don't have easy access to said guns or any other types of weapons. Also with medication, you want to make sure it's locked and it's in a safe place so that people don't have easy access to those things, so that they can make sure that they're safe.
Awesome, thank you.
You're welcome.
All right, so my next question is for Bob, and it's that there's a lot of misinformation and stigma around mental health, depression, and suicide, but you and your Centerstone colleagues in Florida are hosting an event to help raise awareness. Could you tell us a little bit about that event?
Sure. For the last 18 years, we've hosted kind of a 5K, 10K walk-run event to kind of enlighten people as to the issues around depression, kind of bring it out in the open and let people feel kind of comfortable with discussing issues of mental illness or mental health challenges, basically to kind of try to break the stigma that comes with having some of these brain disorders, and just kind of letting people also know that since suicide is 100% preventable, that there are lots of things in the community that we can offer to make sure that that suicide as a way to deal with depression or anxiety or stress or whatever is something that can be treated and avoided. And we've been doing this now for 18 years. This year, we are doing it virtually. So instead of a local event here in Bradenton, we are going international. So anybody in the world can participate in this year, starting on Friday and going until the 26th of September. We're putting a call out to everybody that they can sign up for our 510K and do it wherever they're at, and just notify us that they've done it. And in that way, they're participating in our awareness program internationally. So I, for one, would love to be doing a 5K through Venice, I think, but that's kind of not in the cards for me. So, but if you are listening to this in Venice, I highly encourage you to kind of sign into our website and do a 5K through the streets of Venice. I think that would be wonderful.
Awesome. So yeah, as he said, that is our life story event that's held in Florida every year. And if you look in the comments on this video, you can see that there's a link to that event. And there's still time to sign up now, so you can do that. And then can I have a follow-up question for you about
Sure.
that? So why is it important to have these conversations in an effort to reduce stigma? And how is stigma so harmful within this conversation?
I mean, one of the issues with stigma is it really keeps people from accessing the care that they need. So it causes embarrassment and shame and guilt, and but more often it just shuts down the conversation that anyone might have with their fellow family members about what's going on in their heads, the kinds of things they're thinking about, and certainly in accessing care. So stigma really is kind of the worst thing that could happen to someone is feeling so alone that they can't even talk to their loved ones about what's going on with them. And stigma really can seep down deep into us and have us avoid those really important conversations that might save our lives. So that's why it's really important for us to have stigma go away. And part of how we do this is by educating people about the source of mental health problems and depression and these issues, that more and more we now know that there is a real biochemical and brain disorder kind of aspect to all of these things. It isn't something that you can wish away. It isn't something that you can just wake up one morning and say, oh, I guess I won't be depressed today. There's really some real medical reasons why this is going on. And we certainly do not, if we break our leg or whatever, we don't keep that hidden from the family for fear of going to the doctor. Like that would be a weird thing to do. Yet, if we're feeling particularly depressed and have for some period of time, we may hide that from our parents or our significant other. And that's what stigma does, is it keeps us hidden when we should be right out there, connected with others who can help us and love us and kind of show us that there is hope. And so that's why stigma is just so awful.
Awesome. Thank you so much. Yeah, it seems like definitely eliminating that stigma is an amazing first step to actually having these conversations. So that's great. And then also, just as far as Life Story goes this year, as it's going virtual, just what are you expecting kind of overall, like that difference to look like?
Well, in a lot of ways, like Life Story over the past few years has been kind of a visual treat, because we've had thousands of people line up in the early morning hours, because it is Florida, um, and uh, and start their runs, and there have been cheers as people come across the finish line for our 5 and 10Ks. So all of that excitement um, won't be present this year, courtesy of our pandemic, um, but it was also a very local event in a lot of ways. And so while we're missing out on that excitement locally, we won't have masses of people running around. Um, I think we're all excited about the potential to, like I said, go international with some of this, and see what kind of response we get from all over the world to being aware of mental health issues and the issues of kind of suicide prevention. So while the pandemic has taken with one hand, I think we've taken the lemons and made some lemonade here, and I'm hoping that the Life Story event this year will produce some very interesting results. One of the things we're asking people to do is, since they can run anywhere, uh, to let us know if there's any interesting events that happen during their run, um, and just kind of keep us in the loop about their experiences as they do Life Story this year, wherever they're at.
Awesome. So yeah, if you do end up taking a part in Life Story, you can use the hashtag Life Story 5K or hashtag Life Story 10K. And yeah, we have folks already registered on different states across the U.S. With potential for even more. So that's very exciting. So my next question is for Bree, and it's, what should people know about warning signs of suicide? If I know someone who may be experiencing a crisis, how can I be supportive?
That's a fantastic question. And it is one that I think, having been in suicide prevention research for about 10 years, can feel a bit daunting, even for those of us that have been doing this work for a long time, not only as researchers, but as clinicians, right? So for many clinicians, and I don't mean to sound alarmist, but many clinicians don't get very much training in how to identify suicidal patients until after they finish their graduate work. And so one of the things that we know is just how important that is. We have a workforce of clinicians that are not only destigmatized, that create a warm and safe space for folks to be able to share, but that can also identify and elicit what we call disclosure. So even if a client might not be willing to share overtly that I'm thinking about killing myself, or I think I want to die, having clinicians that know whenever there might be some dancing around, for example, of suicidality, so they can elicit that from the client. But that's a thing that we don't have to restrict just to clinicians, folks that have been trained for years to do this work. This is a thing we can generalize to everybody. And so one of the things that we know is from the research is, over the past, really, suicidology and the study of suicide has been around for a little over 100 years. But through all of that research, right, that's a long time and a lot of data, that there have been upwards of 5,000 suicide risk factors. And I don't know about y'all, but I can't remember 5,000 of anything. And so that is part of where Thomas Joyner's theory of the interpersonal theory of suicide comes in. It's the most evidence-based model of actually predicting high lethality, attempt, and death, right? And there are, again, only those three things: perceived burdensomeness, thwarted belongingness, and acquired capability. And if we can keep an eye out for our friends and loved ones or colleagues that have a sense of not feeling like they belong to anything anymore, this can be folks that, for example, that might have just retired. They have an entire career that really defined who they were and how they contributed to their family, and they don't have that anymore. That is a conflict that we see really prevalently in in veterans and members of the military. Folks that after they've deployed, they come home, they don't have that close-knit bond that they might have had with their unit, or whenever they are discharged from the military after active duty, they don't have that. That was all of who they are, and they don't have that anymore. That's a thing we also might find in students that go to college far off from home, and they might be going to a college that they don't have any friends or folks that they know. And so really just that sense of disconnect. They were connected and then they're not anymore. That can really serve as a true north for us. And again, the second is this notion of perceived burdensomeness, this belief that I would be doing everyone around me a favor if I were gone. And what that does is that really turns the notion that suicide is selfish on its head, because most people who go on to die by suicide or make a highly lethal attempt genuinely believe that they're doing us a service by removing themselves from a family or a system or the world in general. And there have been several writings about that. Thomas Joyner has several books about that that are just really enlightening. As one book, it's called Why People Die by Suicide. Short book, you can get on Amazon for about $11, and it is absolutely fantastic and really goes into some of these constructs in great detail. And then again, finally, is the acquired capability piece, and that can manifest in a few different ways. Again, there's got to be a psychological fearlessness about death, and that can come in a few different ways. One of the things that we know is that folks that have a profession or a history where they're constantly or consistently confronted with death, or that they work with death often. When we think about medical providers, members of the military, these are folks that have seen, or at least been face to face with really the finiteness of what it means to be alive, and they've at least seen what death really is. And so that creates essentially for lack of a better term, a tolerance to the idea of dying. And then a notion of acquired capability is a physical pain tolerance. And so these are, it essentially, with suicide, it often hurts to die. And so there has to be essentially a preparedness to tolerate the pain that will come along with death. That's one of the reasons why we see so many people that are suicidal, but that don't actually go on to attempt with a highly lethal means. And again, that is not to say that much larger group of folks that are suicidal don't present with burdensomeness and belongingness, that they don't deserve treatment, that they don't deserve access to good care, that we shouldn't treat them with just as much seriousness and compassion as someone that does have the acquired capability piece. That is really just a way for us to think about who among us could be at a heightened level of risk of suicide. Because one of the things that we also know is that suicidality manifests in a lot of different ways, and it tends to happen developmentally. Suicidality doesn't just happen in a vacuum. A person just doesn't wake up, kind of as Dr. Boxley said earlier, they don't just wake up one day cured from depression. They also don't just wake up one day suicidal. That's just really not the way that suicide tends to work. It tends to happen over really a lifetime's worth of loss, of the lack of ability to make meaning of that loss, of traumas, of again, a sense of disconnection. And so when we kind of think about our friends and our family members, it's really rare to find someone that doesn't have some degree, or hasn't at some point in their life, has some degree of a desire to die. And to Dr. Boxley's point about stigma as well, when we think about this burdensomeness and belongingness piece, the notion that the vast majority of us, most adults, most people in general, have had at least a fleeting notion of a desire to at least not be around anymore. I'm a person with lived experience with suicide. Many people that I know and love are people with lived experience with suicide. And so it is a much more common and normative experience to have a desire to die at some point. And so by creating that space, one, just having an awareness of what to look for, but also creating a space to where suicidality is normal and it's okay. This is the best place for you to be suicidal. If you're going to be suicidal anywhere in the world, I want you to be suicidal here with me. That's the thing I tell all of my clients. And again, that's a way to kind of facilitate that disclosure, but that's a thing that can also work with friends and family members as well.
Awesome. Thank you so much. And so I have a follow-up question to that, and this can be just for anyone. And actually, Bob, were you thinking about saying something in response to that?
Yeah, I was going to mention being also a child psychologist. There are a lot of things that both parents can do and really kind of educators can do to also mitigate and develop some protective factors with our kids, because we are seeing very young kids developing some pretty serious suicidality, and some protective factors that are pretty good protective factors involve, first of all, being connected, as Bree was saying, to your kids, and not being afraid to bring up this topic directly, because there is really an idea that if you ask about suicide, you will actually put this idea in a child's head that they hadn't thought of it before, and suddenly you've created something that didn't exist before. And the evidence is pretty clear that that does not happen. Okay, if you ask a kid about whether they're having thoughts of harming themselves, and they are, they will tell you, or they will be much more likely to tell you than offering it up themselves. And if you ask them if they're feeling suicidal and they aren't, they will look at you like you have two heads and go back to the playground. So it isn't like you are creating a problem by asking. Some other things that have proven to be very helpful from a research standpoint is training our kids to have really good problem-solving skills and some really good conflict resolution skills, because some of these things, as you were saying about whether you're worth being around, using good problem-solving skills and developing like ways to manage stress in young kids, elementary school kids, middle school kids, that young, really pays off throughout their entire life, because it really does armor them from having kind of these kind of lethal reactions to stress and economic and housing insecurity and some of the other losses that they may feel in the future, if early on we develop some really good problem solving mechanisms in them. And that is something we can do in the home. That is something that a curriculum in a school could also provide, but this is something that you can find like really good problem solving exercises to do with your kids, and you can also model really good problem solving, and if you do that, it really does protect your kids from some of the stuff that we're discussing today.
So to echo what Dr. Boxley has said, I worked in school-based therapy for quite some time. So I have a pretty good experience with elementary age students. And he's absolutely right. If they're not experiencing suicidal ideations, when we would have to ask those questions according to the Columbia screening, most children would like, why are you asking me that? And I'm like, okay, I just want to make sure you're safe. You know, I'm just doing my job. But at the end of the day, it helps desensitize them to those questions. And if I can plug, school-based therapy is an awesome tool to utilize, you know, for children who are experiencing issues, you know, anxiety, depression, ADHD, whatever the catalyst may be, or some of those more extreme traumas that our children are experiencing. You know, the pandemic itself has been traumatizing for some students, or the racial pandemic that we have been experiencing this year has been pretty traumatizing. So I think it's very beneficial to have students participate in some type of therapy, group therapy, individual, whichever may be available to them. School-based therapy is a great tool because it helps normalize some things that they may be experiencing. It helps give them the psychoeducation that they need to understand, because as Dr. Boxley said prior to this, to really try to end the stigma around mental health as well as suicidal ideations, particularly in certain communities, is not something that we really talk about. So, you know, engaging them in counseling or in school-based therapy, or, you know, even bringing them to our outpatient clinic, it will help students to learn those coping skills that they need. It'll help them to find their own voice, to talk about, you know, their feelings and emotions, because it's not something that we normally talk about inside the home. So I'm a huge advocate for helping our children to learn that they can be normal and there's nothing wrong with how they feel.
Awesome. Thank you so much. So as a follow-up to all of that everyone said, and anyone can answer this, if you know someone and you can tell that they are maybe having either suicidal thoughts or just any of these signs have appeared in their life, what's a good first step to take toward that? Like, how do you approach that gently, especially if, like, even withdrawn from you and kind of are like seem like they wouldn't be open to that? What would be a good first step?
I know for myself, I kind of feel that as friends and family and loved ones, on some level, we have to be a little fearless, and we have to go where we would rather not have to go, and directly ask somebody in a loving, caring way what's going on with them, because there's a whole lot of privacy, that we want to give everybody a fair amount of privacy in their lives. But this is not one of those instances where privacy is really a good idea. This is an instance where we have to kind of step up and go and have that discussion and bring up that topic, even in situations where you normally would not.
And to piggyback off that, I think this is an opportunity to kind of demythologize some of the things that we think about suicidal folks, right? Is the notion that if I ask someone, are you suicidal, will that put the thought in their head, or will that make them more suicidal? What the research tells us is no. That, again, like I said, it's much harder to die by suicide than just that. Just asking a question is by no means that powerful. So you can ask the question all day, it won't make anyone suicidal. But one of the other things that we've learned in the research from folks that have attempted suicide that have lived, so this population of folks that have this very real, close lived experience with what it's like to want to die, and want to die so much that they really tried to, what they tell us is that whenever someone has asked them, are you thinking about suicide, it was an olive branch, that actually created a sense of space and a sense of belonging, because because this is usually as a thing that we keep secret, again, because we either don't want to be a burden or because of the stigma, right? And so whenever someone asks you directly, are you thinking about suicide, for the suicidal person, that gives them an opportunity to really be themselves and to share, yes, I am. And if for nothing else, even if we don't have a clinical expertise, or we can't take them somewhere to a hospital immediately in this moment, they might not even need that, but just to have that space to share that they're feeling suicidal, that life has gotten so painful for them that they don't want to live it anymore, that alone can serve as a really significant protective mechanism. There was a guy who he's in the lived experience community. I saw him speak at a conference a few years ago, and he was actually on the Golden Gate Bridge and was preparing to jump. And he said that if one person smiles at me, I won't jump. And so just that one tiny connection, again, can be protective. And so, again, just like Dr. Boxley said, just a willingness to be uncomfortable, to hold that space. But again, in that space, really the only thing that we need to do more than anything is to be present, to be compassionate, and to give people a space to be suicidal. Again, one of the things I say to friends, family, and clients is, if you're going to be suicidal anywhere, I want you to be suicidal here with me. And that has proven to be really quite effective for eliciting disclosure and creating a safe space for folks.
Awesome. And Jashari, would you say that looks any different for like younger people that you work with, like that kind of approach, or are they like more or less receptive or anything like that?
I think with younger students, it's really important to build that rapport and build someone that they can trust, because they may not feel comfortable telling their parent or, their guardian about their suicidal ideations, but being their clinician and creating that safe space for them, it definitely gives them the opportunity to really open up and share those thoughts. And, like what Bree was saying, just really creating really a non-judgmental atmosphere, and not bringing in those preconceived notions about suicide or putting those thoughts in their head, just really allowing them to be in their space and allowing them to be open and honest about where they are, so that you can provide them with the resources that they need to make sure that they're okay.
Awesome. Thank you so much. Okay, so I'll go to the next question, and this one is also for anyone. Are there any mental health treatments or prevention efforts that we can look forward to in helping improve mental well-being and reduce suicide in our communities, just within Centerstone that we're doing, or otherwise?
I am happy to share. Oh, sorry, wrong.
Okay, now I'm back and being a person again. I am very happy to share that in 3 of our states, we recently received 3 COVID suicide relief grants. And so that will provide us some space and infrastructure to build out treatment and training for clinicians in suicide-specific evidence-based practices. And fortunately enough, there are several of those. On the not as fortunate side, just with many evidence-based practices in real-world care settings, they can be difficult to implement. It's hard to get folks trained. It's hard to stand them up. But with these grant mechanisms, we are able to do that. So over the next 2 years, and we also just got a Zero Suicide 5-year grant, which will allow us to train all of Centerstone's clinicians in these evidence-based psychotherapies and treatments that are designed for suicide. And so just to name some of those off, one is called Relate, and it's a treatment that Dr. Lockman and myself actually developed a few years ago that is based on the interpersonal psychological theory, and we built that in collaboration with Thomas Joyner. Another is called SNET, and it is suicide-specific narrative exposure therapy. Dialectical behavior therapy is a treatment that has extensive research and support for working with suicidal clients. Another is cognitive behavior therapy for suicide prevention. And another is called OSSIP, and that is a treatment. It's a very brief treatment that's designed for folks that are recent suicide attempt survivors. So over the next several years, we'll be developing trainings in our simulation center to train clinicians and to be able to, for clinicians to actually practice these skills before they go out and work with real clients. And so, and that's within our grant-based environment, but within our Zero Suicide efforts just across Centerstone, being able to build and disseminate trainings that really facilitate clinicians having the competency and the comfort and the confidence to work with these clients has been a pretty significant step for us. So that is, those are some of the endeavors on our end. But I would like to punt to Dr. Boxley and Jashari about treatments that exist or might be able to be modified more specifically for younger kids, because the majority of our work has been with adults.
My sense of it is that school-based interventions are going to be like the primary avenue for any kind of decent intervention with kids. That is a place where you have the maximal number of kids. You can disseminate information very freely, and I believe that a lot of work, particularly in coping skills, like engendering coping skills with elementary and middle schoolers, really does have some long-term benefits. One of the challenges is getting school systems on board with these interventions. So there are some challenges to implementing these things, because a lot of school systems are very concerned about having us come in and implementing an evidence-based intervention for depression or anxiety or suicidality. Once again, with the idea that if we talk about it, we make it so. And so a lot of it doesn't surprise me that we get so much funding for suicidality with adults, because implementing programs for reducing suicidality in kids is fraught with kind of institutional anxiety, parental anxiety, and frankly, clinician anxiety as well, because there aren't that many child clinicians out there that are comfortable in this. So it doesn't surprise me at all that that evidence-based practices are veering more towards the adults, which is a concern since what? Is suicide the third largest cause of death, 10 to 25-year-olds? So we should be doing something. And you asked like what? I really think there needs to be a whole lot more research on what is the best way to intervene with these age groups. Because the approaches we're taking now are kind of cobbled together from what we know works with adults, just downsized for kids. And that is not really a fair way to do it. There are probably some really wonderful interventions out there for children that need a fair amount more research to make as an evidence-based practice, and a whole lot more buy-in from school systems. I was listening to a conference, and there's a study, I think in North Carolina right now, and they were able to get into the school system and do 100% assessment of all the kids in the school system. And what they found was 2 kids in every classroom had not just mild, but major suicidal thoughts. 2 in every classroom. And this is a middle school. So that is a very, very serious lack. And we just need a whole lot more research and funding. But if I had to like do something right now, I would say we need our school-based counselors and need to have a presence in the school and easy access to them, so that we can implement what we know individually while we wait for the research to help us figure out what we can do on a school-wide setting.
Awesome. Yeah, Jashari, were you saying something as well?
Well, yes, I saw in the chat about advocating for school-based therapy in your town. So I'm not really sure where you are. But how, we go into different communities is really kind of sometimes word of mouth. We here in Hamilton County, I am providing school-based therapy for Hamilton County, Ray County, Sequatchie, Marion, and Bledsoe. And then in Cleveland, they cover several other counties as well. So we started out here in Hamilton and kind of continued to branch our way into other school systems. So in terms of Centerstone providing that school-based therapy, I think to talk to your school, to talk to the school board to see if that's something that they would be interested in, creating memorandum of understandings, making sure that your particular Centerstone maybe has a school-based department. If not, then, I'm sure that's something that can get started. I think, school-based therapy is such a great asset to children. Because prior to me becoming a clinician, you would hear and see about adults with mental health issues and not necessarily think about it being an issue for children. And when I stepped into the realm of school-based therapy, my mind was blown with what our children experience. And sometimes that continues into adulthood. So if you're working with children, that can maybe help alter their trajectory of what they will experience as adults. So I agree, more research would definitely be an asset to us. However, I think a really great asset to school-based therapy is being able to offer family therapy. And I think that's the tool. You have to educate parents and families on mental health and get them involved in the treatment, because the child can't just do it on their own. So bringing the parents involved, excuse me, helps break down some of those generational patterns that we see in families for far so long. And it's a great way to house that in the school, because they don't have to go anywhere. You don't have to pull the child out to go to their appointment and maybe they miss a half a day or a whole day, or whatever the case may be. So school-based therapy is an excellent tool to have in schools. If we could get it across the nation, I think we would be better off.
Definitely, that sounds really helpful.
And one other thing about that is that in talking with the school system, because I worked in a number of school systems in school-based therapy, this is going to sound kind of unfortunate, but you really need to talk to the school district and the school about self-interest, their own, because the absence of having these services in the school really puts the school at risk of having all kinds of problems that we would otherwise mitigate or even stop from happening to begin with, okay? And the absence of these services in those schools cause a lot more violence. There's a lot more difficulty in management, and there's pretty good research that people's grades improve, people's kind of general well-being improve. So the answer to your question is, I would hit the school district with this is an enlightened self-interest thing. And it also will save them money in the long term, because they will have to afford fewer resource officers, fewer school counselors, fewer whatever, if we're in there helping in a direct way, giving like evidence-based interventions for the kids in the schools.
Awesome. And I know, Jashari, earlier that you mentioned kind of obviously the difficulties with the pandemic, and also even with the social epidemic in America and everything going on there. What are ways that you've kind of felt it helpful to increase efforts, especially with working with children on this issue?
I will say, I guess right after the murder of George Floyd happened over the summer, I had a clinician come to me who works in one of our inner city schools, who had a lot of children who were afraid for their own lives, that they could end up in the same situation as George Floyd, being African American children. So I think it's really important to have, clinicians available to talk to kids about what's happening. To really be open and honest to some degree with them. And again, bringing in the families, because I think to have a family conversation about what's taking place in our nation is just really important to facilitate, and to help them with some of those fears that they have, or some of the trauma that it may invoke in some of our children, because what we have experienced to date has been very traumatic. And, not just because it's playing out in the media, or, we have access to seeing things happen in real time, versus maybe when things happened 50 or 60 years ago, we didn't have social media to where it happened instantly. So the replaying of what we see can be very traumatic, not to mention what may be taking place in some people's communities. That also adds to some of those triggers and some of those trauma responses. So I think it's really important to talk about how it can produce trauma, what some of those trauma responses look like, how to implement coping skills when you are triggered or aroused by things that are taking place, or, learning to take a break, because it can be a lot. Things that continue to happen, it seems almost like every day or something once a week. So I think it's really important to have those conversations, to reach out to communities to have those conversations, just to answer questions for people who don't know how to have those conversations with their children, on a social and emotional level, and what that really looks like, and how to provide support to our communities and our families.
Yeah, awesome. Thank you so much for speaking on that.
You're welcome.
So I think that probably about takes up all of our time for today. And I just want to one more time reiterate that we have crisis line information available in the comments. So if you or anyone you know are experiencing crisis, or are possibly at risk for experiencing crisis, just have that information on hand so that you can reach out at any time. And I really appreciate everyone giving up their time today to join this conversation. And I'd like to remind everyone that this video will still be up on our Facebook page afterward, so you can check it out whenever you want. And also we have further resources at centerstone.org /suicide. And you can also call our main phone number at 1-877-HOPE-123. And we'll be having 2 more live chats during this month. So next Tuesday, we'll be talking about BIPOC and suicide within that community. And the week after that, we'll be talking about LGBTQ+ and suicide within that community. So thank you to all of our speakers, and thank you to everyone for joining. And yeah, that was a great conversation. And I'll let you get back to your days. Yeah, have a great day.
Thank you all.
Thank you.